Everything in cardiology can be understood through one diagram. It's called the Wiggers diagram, and if you master it, you can reason through almost any clinical scenario. The cardiac cycle is divided into two main periods: systole, when the ventricles contract, and diastole, when they relax and fill. Within each, there are multiple phases. Let's walk through one complete left ventricular cycle. We start at end diastole. The left ventricle has just finished filling. End diastolic volume is about 120 milliliters. Left ventricular pressure is low, around 5 to 10 millimeters of mercury. The mitral valve is open. The aortic valve is closed. Phase 1 is isovolumetric contraction. Electrical depolarization reaches the ventricle, the QRS hits, and the left ventricle starts to squeeze. Pressure rises rapidly. The moment left ventricular pressure exceeds left atrial pressure, the mitral valve slams shut. That closure creates the S1 heart sound. Now all four valves are closed. The ventricle is squeezing against a fixed volume. No blood is going anywhere, but pressure is climbing steeply. That's why it's called isovolumetric. The volume doesn't change. Phase 2 is rapid ejection. Once left ventricular pressure exceeds aortic pressure, around 80 millimeters of mercury in diastole, the aortic valve snaps open and blood shoots out. Ventricular volume drops quickly. Pressure continues to rise to a peak around 120. Phase 3 is reduced ejection. The ventricle is still contracting, but more slowly. Pressure starts to fall. Flow continues, but at a slower rate. Phase 4 is isovolumetric relaxation. The ventricle starts to relax. Left ventricular pressure falls below aortic pressure, and the aortic valve closes. That closure creates S2. Again, all four valves are closed. No blood enters, no blood leaves. But now pressure is dropping rapidly. End systolic volume, what remains in the ventricle after ejection, is about 50 milliliters. Subtracting from end diastolic volume, that gives us a stroke volume of about 70 milliliters per beat. Ejection fraction, stroke volume divided by end diastolic volume, is normally 55 to 70%. Phase 5 is rapid filling. When left ventricular pressure falls below left atrial pressure, the mitral valve opens and blood rushes in from the left atrium, which has been collecting pulmonary venous return. Most ventricular filling happens here, passively. Phase 6 is diastasis. Filling slows as atrial and ventricular pressures nearly equalize. Phase 7 is atrial contraction, the atrial kick. The P wave fires, the atrium squeezes, and it pushes the final 20% of ventricular filling. The cycle then repeats. 4 heart sounds correspond to 4 mechanical events. S1 is mitral and tricuspid closure, the start of systole. S2 is aortic and pulmonic closure, the start of diastole. S3, when present, is caused by blood rushing into a compliant or failing ventricle during rapid filling. S3 is normal in children and young adults. In older adults, it's often a sign of systolic heart failure. S4 is caused by atrial contraction, pushing blood into a stiff, non-compliant ventricle, classically seen in left ventricular hypertrophy, hypertensive heart disease, and aortic stenosis. Clinical anchor. In atrial fibrillation, the atria don't contract effectively. There's no organized atrial kick. A healthy young heart tolerates this fine. But in a patient with left ventricular hypertrophy or heart failure with preserved ejection fraction, that 20% from the atrial kick is essential for filling. When these patients flip into atrial fibrillation, they can decompensate acutely. That's why rate control and rhythm control matter so much more in these populations. Master the Wiggers diagram, and you're reading the heartbeat by beat.